Flagstaff. So you're somebody who not only knows what's going on is up to date now, but you also have that history of what it was like to begin with telemed. And I know you've done it long enough that you've probably bumped into whatever obstacles and dilemmas that are likely to come up for people. So would you like questions and answers, or do you just want to give us an introduction and, you know, how would you like to do this?
Yeah, I think question and answers always work well. Yeah, so, you know, as you said, we had telemedicine with Flagstaff for many, many years. And then because Medicare has so many restrictions that, you know, the Skype program that we were using, they didn't like that after a couple of years, and they felt that it wasn't strong enough for HIPAA compliance and that we had to stop it and send it to Banner, to use the Banner system. And that's who's doing Flagstaff telemedicine. But we've been doing telemedicine with Yuma, and then hopefully we're going to start soon with telemedicine in Prescott. Hopefully we can get that off the ground.
Oh, and I do know that people in Prescott are so eager to have a movement disorder specialist, and that's such an advantage for these areas that they may have some general neurologist, but that group up there has yearned for a movement disorder specialist for years now. So I think they're going to keep you busy.
Right, exactly. So, but what, you know, whatever questions you guys have, whether it's telemedicine or Parkinson's disease or medication, I'm happy to answer it. And I think that more and more patients are getting up to speed, you know, now that PMD Alliance has been doing their Zoom tutorials. Certainly I've seen that more and more patients have downloaded Zoom either to their iPad or their phone. And I've had 2 visits with people on their phone today and yesterday, and the iPad. So as long as you have an iPad and you download the Zoom app, it works quite well.
Great.
Excellent. So if anybody does have a question, don't forget you're all muted right now. So if you have a question, maybe wave if you don't know how to unmute yourself, or I'll help unmute you. So if I can see, it looks like Mira has a question. Mira?
All right, that's okay. One more question. Are doctors allowed to go over the borders of their states?
Yeah, so has been some loosening of restrictions where we can now practice across states without a state license, or some states like New York, you can now get a New York license in 24 hours if you're going to go and work in one of the ERs there.
Wow.
Certainly for
I bet.
Exactly. Something that used to take 9 months, you can now get 24 hours. But it has loosened the restrictions with, let's say, from Arizona to New Mexico. So, you know, we could do telemedicine with New Mexico without a lot of problems. I think that will go away after the COVID pandemic because it's all about states' rights.
Really?
Yeah, but I mean, I think, you know, the more patients push and write their congressmen and their senators and say, you know, hey, we need to join the 21st century, you know, the more these, you know, laws will be updated.
Great.
Yeah, good.
Okay, it looked like Denise was raising her hand. Denise, you need to unmute yourself.
Hey, Doke. Hello, everybody.
Hi, Denise.
My husband and I, we're going to have his first telemedicine appointment tomorrow with his neurologist. And I guess I'm kind of trying to figure out what sort to expect. But one of the reasons for his visit is he's recently been presenting with, can you hear me?
Uh-huh. We can hear you.
Okay, I said my connection's unstable or something. He had orthostatic hypertension. So have a blood pressure and a wrist and a cuff home. I think that's something that we will to accomplish telemedicine. And what things would a disorder doctor be able to check for on this format? Thank you.
So for orthostatic hypotension, I think I heard you correctly that you do have a blood pressure cuff at home. So we'd want to know your blood pressure sitting and standing. So first take the blood pressure sitting, and then wait about 5 minutes, and then do a blood pressure standing. And then you want to know all of the medications you're taking, especially any blood pressure medicines or bladder medicines that you're taking that could also lower the blood pressure. And that way they can make some better evaluation of whether they need to change your medicines or add new medicines to artificially keep the blood pressure up. But if you have a blood pressure cuff, we want orthostatic blood pressures would be sitting and standing. And if you could do, I mean, the visit is tomorrow, but for the next visit, if you could have like a week or two once a day after your first dose of levodopa, then it would give us a much better idea of what's going on with the blood pressure and how your Parkinson's medicine is affecting the blood pressure.
Great.
Thank you. Thank you.
And then I saw John Keating had a question, so let's unmute you. Can you unmute yourself? I may have just muted you back up.
There we
go. I did it again. There you go. Stop. There we go. We're unmuted.
Okay. Okay. I just had a question as far as the technology is concerned. As far as using the phone, I was actually told by someone that there can be difficulty in establishing the connection if when using a phone, you just click on a link to join a Zoom meeting. And what you really need to do is make sure you have the app installed first on the phone. Can anybody speak to what good looks like when, you know, accessing a Zoom meeting from an iPhone, and difficulty that they've had or as a result of either having the app installed or not installed?
Yeah, so yesterday we had a patient, she had an iPhone, and so once she installed the Zoom app, just like you would install it on your iPad, then she was able to click on the link, and then it works just like FaceTime. You know, I would see her just like I would in a FaceTime. So she was by herself, so it was a little bit hard for her. Like we had to put the phone on one side of the room and then have her walk so I could see the festination. So it's always helpful if you have somebody with you. That way they can, you know, point the camera so I can see the tremor, or see the walking, the gait, the balance. But once she installed Zoom on her iPhone, it worked. Today, this morning, we had a patient who had an Android phone. And then even after he downloaded from the Google place, the app, it still didn't work. It sent him to some other room. So we were in two different rooms and we couldn't see each other. So that didn't work today, but I don't know why that was.
Okay, well, I just want to remind, Rachel reminded us all, if you're kind of don't want to ask a question, you know, on the video, feel free to use our chat feature that she sent a chat to everyone, that you can also type in your questions and we'll see them. And you'll be able to have them answered that way. Anybody, who's next? Who else has questions? All right.
Lynn?
Hi.
Hi, Lynn.
I wanted to know if anyone knows how to move the tiles around, because my picture's on one screen and the speaker is on a different screen. And when somebody comes on to talk, it's sort of fun to see their face. So anybody, I got it in the 9-picture grid form right now. Is there any way you move the pictures from grid to grid?
Well, so there are a couple of different views, depending on if you're on your phone or on a computer. But you see in the top right corner of where those boxes are, there should be a button that says speaker view.
I have switch corners.
Not that. There may be a button that
switch to active speaker. Is that it?
That's it.
Yes, that's it. So you can toggle back and forth between those two screens, where you can, if Dr. Ospina was kind of going over a lot of information and we may just want her on the screen, we can adjust the screen to have it just be her who's speaking. Right now it's probably me. And so you could go back and forth to see everybody, which we like to do because we like to sort of keep an eye if there's anybody waving or wanting to ask a question.
Thank you.
Sure. All right, so is anybody waving?
I have a question, Dr. Ospina. So Lynn's question about having the multiple boxes prompted this. Do you, with Zoom, in essence, even if, you know, my parents live on the East Coast, I could technically join their telemedicine appointment, right? Do you ever have that, or are there any like HIPAA restrictions around that?
So no, I have had, I mean, I think as long as the patient knows and is aware, then, you know, they can join in. When we had that situation I did the Tucson telemedicine on Monday. So we had the daughter hook in and then the patient. And also we've had for Duopa patients where we had to reprogram a pump. We had the Duopa nurse come into Zoom and help us with the programming. And so all three of us were in the same Zoom meeting. So as long as the HIPAA, I mean, as long as the patient is aware and it acknowledges it and says, yes, I don't mind having another patient or another person see me or talk about my disease, then it's okay. And I prefer that, like the patient on Monday, you know, her understanding of how we were changing the medicines were completely different from what I was actually explaining to her. And it was really important that the daughter was there, the daughter who was the one who was, you know, putting all her medicines in her medication pack and how she was going to take them, that she was there so that she understood what we were trying to change. So especially if there's any mild cognitive impairment or some dementia, and if the daughter or the son is taking care of the medications, we always want them there if possible. And with Zoom, then that's easier.
Yeah, that sounds like that'd be a great benefit for families to have someone join in, just as you know, you'd encourage them to bring a family member with them to an appointment in your office.
Yeah, many times in the office, we'll have one of the kids, you know, they'll be on FaceTime or they'll be on the phone, or the spouse will be on the phone if they're at work, and so that they can be in the appointment at the same time, even though they're remote.
Yeah, that's good.
Would you guys want your bossy daughter-in-law from across the country to join in?
That's a touchy
That's not
subject.
me. I'm asking for a friend.
Yeah. So, yeah, you might not want to bring it up until you're ready to invite people to join you in your appointments.
But I think that the more eyes and ears hear the appointment, the better it is, because many times, you know, you think you're explaining something and you think the patient is understanding what you're explaining, and they're not really understanding. So if there's more than one set of ears or eyes listening, then I think that's better. Or they may forget by the time they get home, they forgot, you know, was I supposed to take it every 3 hours or every 4 hours, or was it 1.5 tablets?
You've got backup.
Yeah, you have
other people listening. Exactly. Carol, it looks like you have a question. Is that right, Carol?
Yes.
Okay.
Our primary doctor added Abilify to the medications for my husband. And the physical therapist today said there was like a level 3 warning for that drug with other Parkinson's medications. Is there anything that we should do? Should we call the primary doctor? That's my question.
Yeah, so Abilify blocks dopamine. It's an antipsychotic that blocks dopamine. And so we don't like to use it in Parkinson's disease because it blocks dopamine and it makes your motor symptoms worse. So in patients who may have hallucinations, mood disorders, anxiety, depression, we like to use Seroquel, which is a lot more gentle, doesn't block as much dopamine as Abilify. Or if the problem is just hallucinations, there's no depression, there's no anxiety, then we can use Nuplazid, which is very safe as far as the PD motor symptoms in Parkinson's disease. And then we just, you know, take 1 tablet once a day at night for the hallucinations. But if there's sort of hallucinations and some mood disorder, or there's a lot of paranoid ideation, then we would choose Seroquel over Abilify in a Parkinson's patient.
Thank you.
Okay. Dr. Ospina, that brings up a question. How do you handle prescriptions on Telemed?
So the prescriptions, we get them all faxed and taken care of from the clinic. So if we change your medicines, then we just change, you know, whether in Tucson, I can do it electronically on the computer and send it directly to the pharmacy, or in Phoenix, I can just fax it to your pharmacy. And then we like to do a 3-month supply with 3 refills, so you're good for the year. And now your insurance company should be allowing you to fill your scripts earlier should, the quarantine lasts longer. So you have a little bit more leeway in filling scripts right now.
Okay, that's
Great.
good. And it looks like, Judy Reynolds, you said you can also record on your smartphone, your appointment. Is that, what do you have to say about that, Judy?
Oops, I'm sorry.
Oh, wait a minute, you're muted.
Wait.
Don't talk yet. We got to unmute you.
I feel like all of us are trying to do it at the same time. Judy, can you unmute yourself?
Over in at the lower left.
There you go. There you go.
Well, what do I have to say about that? You can record. So if you go to the doctor alone and you're worried you won't remember everything he said, you have a record option on your smartphone, and so the doctor's okay with it, which you're the patient, so he kind of has to be. You can record your visit.
Okay.
Yes. Is there a way, though, Dr. Ospina, to record maybe the call that happens with the daughter who's across the country? So that's a way that the family can revisit.
Technologically speaking, you would probably have to load some recording software on your phone. And then you would be able to do that as long as all parties, depending on which state they live in, as long as all parties agree.
Right.
So, and I think in Zoom, you record also, but it's only the person who's hosting the meeting can record it. Is that how it works, or?
I think so. I think that the host is the only person. Let's see. I see another question coming in from Mary.
In Zoom, as the host can record, then you can distribute it after the session. So you could then distribute to the patient and the daughter or whomever the other people involved were.
Okay, that's a good.
Participants can record if the host gives them permission. There's a setting to give them permission.
Yeah. Okay, well, so that option, I think the important thing would be to check with everybody and make sure people agree that it's okay to record the visit before doing it. It adds an additional element to that privacy issue to have it recorded.
True. Anybody? Doris. Good morning.
Hi.
Good afternoon.
Good afternoon. Hi, Dr. Ospina.
Hi, how are you?
Just fine. I do have a question about new medications. We just saw a webinar last week about this new spray for off periods. And Bill seems to be having more off periods. Now, what do you think about this new medication?
Yeah, so the new spray, it's called Inbrija, and it's an inhaled form of levodopa. So it's your same yellow cinnamon, but it's in little particles that you can inhale. And the advantage of having an inhaled form of levodopa is that we're not going through the gut. We're bypassing the gut that has slowed down. That's one of the reasons why you have a delayed on or no on period. When you swallow the pills, it might take more than 60 minutes to kick in because it's stuck in the tummy and it's not getting into the small intestine. So inhaling the levodopa and going lungs to brain gives you a quick on from 10 minutes to 30 minutes, and it can last up to 60 minutes. So it's a very good rescue medicine for patients, especially early in the morning before their first dose has kicked in, or in between their doses of levodopa. Let's say you took a dose at noon and then you went to rock steady boxing, and at 4 o'clock, all of that levodopa had been used up. And so that way you could bridge your dose between your 2 doses of oral medications. So the only thing, it's a little bit tricky to use, so that you want to take a little bit of a sip of water beforehand, and then slow and steady, and you might have to do 2 or 3 puffs to get it all in. And a dose of Inbrija is 2 capsules equals 1 yellow cinnamon. So it comes in these little capsules, and you need 2 of those to be equal to 1 of your cinnamon. So you have to do 2 of the capsules. And so many patients cough it out. after you've been using it for about a week or so, then you get used to how to inhale it and you don't tend to cough out the medicine, and then it starts to work. So you just take a sip of water, slow and steady. You might have to, inhale it 2 or 3 times, but then once it gets into the lungs, it's more quick acting, and then it should last up to 60 minutes. So it's a good rescue medicine because we're bypassing the gut. One of the reasons why we have so much trouble with on and off throughout the day is because your medicines are getting stuck in the stomach and not getting into the small intestine where they need to be absorbed. So it's a nice alternative. It's also the reason why we use the Nupro patch. We're going through the skin, bypassing the gut, so that we don't have those peaks and troughs throughout the day that we have with the oral medication. And then the other minus with any new drug, but is that it's the expense. So, once you go through the whole process and the prior auth, then, be sure to ask the company, hey, whatever the copay is, whether it's $35 or $350, just say, I can't afford it. And then they shut you over to some foundations that can offset your copay, whatever that copay is, to make it much more affordable.
Thank you.
Excellent. Very helpful. Thank you. I have a question here from John Keating, who's asking if what patients can do to better prepare for a telemed appointment. Is there anything that they should gather to have with them in front of them, or anything like that?
So for all appointments, not just telemedicine, but all appointments, we always want to know what medicines you're on, and how many milligrams are those pills, and how many times a day do you take it. So if you have that all written down, then it's easier for us to figure out what you're on, especially like there was a question earlier today about orthostatic hypotension. So, if we know that you're also on Flomax and, metoprolol and Tua and Norvasc and another blood pressure medicine, it gives us more of a clue of what is, lowering your blood pressure, instead of just telling me I take a little round pill and then I have a little yellow pill that's oval shape. I don't know what that is. But if I have a list of your medicines and I know how many milligrams you're on and how many times a day, then I can make a much better educated guess of what is going on and how to fix it. And then always write down your questions, and that way you don't forget them before you leave the office or we hang up the phone. So if you have all your questions written down, we make sure that we can get through all of them. So I think those are the 2 biggest things. Is always we want to know your medications, what else you're taking, especially if you started new medicine since your last visit, and then what's going on, what are your questions. And then always, another plug for having other people there, whether it's your spouse or your kids or somebody else or a caregiver, is that many times the patient will say, I'm fine, there's nothing wrong, I feel great. And it's the spouse that says, hey, no, you get dizzy every time you stand up, or, oh, you're dyskinetic, you haven't noticed it, so that you can get another opinion, another set of eyes of what's going on in the home.
Very important. Okay, Valerie Sanchez, I've unmuted you.
Thank you. Hi. Dr. Ospina, my husband was diagnosed a couple of years ago with Parkinsonism as a result of having had the DAT scan. He recently went to a physical therapist, and when we were going over everything as a new patient, she asked us, well, how do you feel he's doing with what he's taking? And we're not seeing, he doesn't have a lot of the symptoms that a lot of the other folks that we meet with that have Parkinson's has. And she said, well, I just want to tell you that I think he actually has PSP. He's got you've told me all the symptoms that he had. She recommended we go to a doctor in Gainesville who specializes in these kinds of Parkinsonism. And we were fortunate, we were able to get something in early May. Unfortunately, Corona beat us to it. We've set up a telemed for same appointment day. We're going to see them. I'm having our doctor send him all the records. We're completing everything with all the meds, but we're wondering, first of all, if you can give us any info on PSP. We don't really think the carbidopa-levodopa is doing anything because he doesn't really have off times. But what can we expect from a telemed visit? What else are they going to do that would confirm for them? Is it just a symptomatic confirmation based on what he's experiencing that they're saying, oh, well, it could be PSP, or is there some other kind of testing?
So the difference between Parkinson's disease and Parkinsonism, or the Parkinson plus symptoms or syndromes, are that Parkinson's disease responds to levodopa. You give the patient Sinemet or levodopa and their symptoms improve. The tremor gets better, the rigidity gets better, the bradykinesia or the slowness gets better. But in Parkinson plus syndromes like PSP, you give the patient levodopa, nothing happens. They don't respond to the medication. Initially, everybody looks the same. Year one, everybody looks like Parkinson's disease. But as the years go on, years 1 through 5, they all develop their different symptoms. So in PSP, you're going to see trouble with the eyes. The eyes go up and down.
Right.
So for your visit, you want to make sure that you could video the eyes, that they can see the eyes and they can do the eye exam and they can see the eyes, whether how far do they go up and can they go down and can they go from side to side.
And does that vision piece, because yeah, I know that test that you're talking, but he tends to, his eyes don't seem to go where, like if he's going to walk this way, if he's stopped or frozen for a minute, his eyes aren't looking, they're not directed at the right place, whether it's somebody talking to him or whatever. Would that description be sufficient, or should I tape that as well?
No, so you'd want to see the eyes and you'd want to see the eye movement. So during your televisit, they would want to point the camera to his face and to the eyes and ask him, can you look up? Can you look down? Can you look from side to side? And if you wanted to, if you could video that, the eye movements and email them to the doctor, then that would be super helpful. So, but that's what they would be looking for. And then the fact that he's not responding to levodopa points you more, and even though there's a positive DAT scan, which we would expect in PSP that it would be positive, the fact that he doesn't respond to levodopa points you into that direction that it's Parkinsonism. And if he develops eye restrictions, then we would call that PSP versus MSA or CBGD.
And are there medications for PSP or not really?
Yeah, so no, we try the medicines. Many times patients have restless legs and they do respond to dopamine agonists like Mirapex or Requip. So we keep them on an agonist for the restless legs. Sometimes they respond a little bit initially to levodopa, so they may be on a high dose of levodopa medicine, but it's not, they just stay on the same dose. They don't, if we escalated it, all they get is the side effects. So we certainly try the medicines and see what we can squeeze out of them, but they don't respond to medications the way Parkinson's disease does.
And the response, the symptoms that they respond to are tremors or leg, whatever you just called it. I forgot what you just said. He doesn't have any of that kind of stuff.
Right. So Parkinsonism, they don't tend to have the resting tremor that's very classic in Parkinson's disease.
Right.
They have more rigidity, bradykinesia, which means slowness of movement.
Yes.
And PSP falls backwards. They tend to be very retropulsive. They develop the eye restriction, so they have a lot of double vision and then they can't look up or look down. Then MSA patients have more autonomic failure. They have more trouble with the bladder and the blood pressure. And then CBGD develops what we call alien hand syndrome. The hand becomes its own thing and it does its own thing, and it's many times in the back of the patient. So as they develop their own symptoms, then we can be able to give it a name.
And do some of those symptoms, what you just described, MSA, the PSP, I go down that checklist and that's him to a T.
Right.
But he also does have bladder challenges.
Yes.
So could it be that some of the MSA he might have some of those as well?
Yes, that's true. So just like Parkinson's patients can have bladder issues and blood pressure issues, PSP. So they don't all stay in their lane. They take from each other, but they definitely have their, like PSP always has the eye problems. CBGD always has alien hand syndrome. So they always have their thing, but everybody takes from everybody else. So it's because Parkinson's disease is not really a disease, it's a syndrome. So everybody is different. Some people have more trouble with hallucinations. Some people have tremor, some people don't. So everybody is different. So it's more of a syndrome.
Okay, thank you very much.
Thanks, Valerie.
And so for your visit, you'd want to have blood pressure sitting and standing if you have a blood pressure machine at home.
We do.
And then they'd want to see your exam and specifically the eyes.
Okay. And are there any other tests that we can anticipate?
Well, they'd have to be done in the office, like checking rigidity, the balance.
Right. Okay.
It looks like Judy's waving. Judy, you want to unmute yourself?
Yes.
There you are.
Okay, I just thought of something while I was listening to her. I had trouble staying asleep at night, so you and my own doctor recommend that I take a continuing release carbidopa levodopa at bedtime. That has worked great, except that now I have trouble falling asleep. So I'll lay awake for an hour or more, and I'm tired, but I just can't seem to, shut my body down. So what do I do now?
Yeah, so for, trouble falling asleep, we can use some melatonin, or if it's the mind racing, we have to quiet the mind. Many times we'll give you a little bit
It's
of...
mostly the body, not the mind.
Is it the body that you have cramping?
Well, it's almost like a restless leg, but not really. It's just, I can't seem to get comfortable, and I'll get up and go to the bathroom 2 or 3 times and walk around a bit and go back to bed. It's almost like I just can't relax.
Right, so then you could start your Cinemet, either the C or the longer acting one, a little bit early, or if you're underdosed. So if you have restlessness or akathisia, where you feel like you have to get up and walk around and you're not comfortable in your own skin, that's due to low levels of dopamine. We have to bring them back up. So, one reason why your doctor may want to use once a day medicines to give you better coverage throughout the day and the night, so that you're not peaking and troughing throughout the day, especially at night when you want to fall asleep.
I don't notice during the day that I have what you would call off time. I mean, sometimes I can forget to take the pill for like an hour or two, and I don't notice any difference. So why is it affecting me at bedtime?
It could be that at the end of the day, you've just run out of gas.
That's probably. Okay, so I'll try taking the bedtime one earlier.
You could try that earlier, especially if you're having restlessness and it's not the mind racing.
Okay, thank you.
Okay, who else do we have? No more questions?
Marilyn. I see Marilyn's iPad, but doesn't look like Marilyn.
Yeah, that's my wife's iPad. First of all, I really appreciate you all, whoever sponsors this, putting this on. It's very informative and helpful. I have a question for the doctor with regard to medications in general that has always interested me. I'm looking for a valid source of reference to monitor to check the interaction of the medications that I take. Can the doctor recommend such a source?
So I'd always ask your pharmacist. So their computer has a little program that can put all your medicines in there and then spit out what are the contraindications. So I would go to your pharmacist first. Many times they're the first ones to pick up a contraindication between 2 medicines that were ordered by 2 different doctors.
Okay, thank you very much.
Great. Valerie?
Valerie?
Yes, one other question, doctor, and I agree with him. This is so helpful. Thank you so much for doing this. Is there any negative impact? Do we have to be weaned off of the carbidopa levodopa?
Not necessarily, but it depends how much you're on. So if you're on 800, 1,000 milligrams, we definitely want to wean you off. If you're only taking, you know, 1 tablet 3 times a day, you could probably just stop that. But we like to wean off medicines in all our patients. And it's more important, the higher the dose of the levodopa, the more important it is to wean off.
Okay, thanks.
But the other problem with the Parkinson plus syndrome is that we push your levodopa dose to 1,000 milligrams a day before we say that you're not levodopa responsive. So if you were just taking 1 tablet 3 times a day and you're not seeing any benefit, we would continue to increase the medicine until you had 1,000 milligrams a day. And if you still didn't see any benefit, then we would consider that an unresponsive patient that looks like a Parkinsonism.
Okay, thanks.
Who else? Dr. Ospina, is there something you'd like to just inform us about regarding telemedicine? Something that we wouldn't even know to ask or think about that would be important for us to know?
Okay. So always become familiar with your iPad or your phone and or where your camera is, because then like when I ask you to put your medicine bottle so I can read it, if you don't know where the camera is, then that's a little bit difficult. So we had that problem the other day. So they couldn't find where the camera was on the iPad. And so we couldn't read the bottle. And so the more you're familiar with all of the technology, the easier it is.
Oh, that's great. And is it better to use a computer rather than a phone where possible?
Well, you know, I found that many, especially if they live in assisted living, they don't have a computer, they just have a phone. And so that using the phone has become really helpful. And now that many patients have smartphones, it's almost like having an iPad.
Right, okay. Well, that's great. Am I seeing any more people who want to ask Dr. Ospina any questions at all?
Marie Powell Daly, I've just unmuted you. Hello.
Hi, I have a question. How difficult is it to switch from the immediate release tablets to a long-acting preparation?
So from Cinemet, the IR, the yellow one to CR, it's not difficult at all. If you're transitioning from immediate release yellow Cinemet to Rytary, that can be quite difficult, especially if you're an advanced patient on a high dose of levodopa. That transition period can be a couple of weeks. And so it's something that you have to stick with and have communication with your doctor of how to titrate up or down from your dose, because it's not a one-to-one conversion between Cinemet and Rytary. So we have to pick a dose and then titrate up or down depending on whether you're very dyskinetic or very off.
Okay, so it's not like a one-to-one.
Yes, it's a process. But if you stick with it, you know, once you get your dose of Rytary right, it works very, very well. And it's a much longer acting form of the medicine. So we could get 4 to 6 hours out of each dose of your Rytary, whereas we can only get maybe 3 hours out of your Cinemet if we're lucky.
Exactly.
Thing about Rytary is that we're not actually decreasing the number of pills that you're taking a day. We're decreasing the number of times that you're taking the medication. So that you might end up taking 3 capsules 3 times a day or 4 times a day. So you're on 12 pills, but you know, we're not taking Cinemet 6 or 7, 8 times a day.
Right. Okay, great. Thank you.
Thank you. I see that I think Myra had her hand up just a moment ago. Do you have a question for us again?
Following through on what we were talking about before about recording, either recording a phone call or recording the computer. Does anybody have any idea how you do this?
When you become the host of a Zoom call, there should be a button that you'll be able to record it. Only when you're the host of the meeting though. So if you are if the doctor is the host of the meeting and you're attending the meeting, you're not going to be able to record it.
Okay.
Does that
answer?
What
about on the phone?
On the phone, I think what Judy was explaining before was that there's a feature on most smartphones that you could just record, sort of like a voice recorder, like if you're interviewing somebody. So
Okay, I'll look
if
into
during your doctor's appointment, you'd like to record your doctor speaking to you, it would just be through your phone and not through the Zoom meeting itself.
Okay, actually, we could record this on our phone if we have our phone on.
Sure.
Right?
Of course.
Maybe.
Just don't sell it to anybody.
Okay, I promise. Thank you.
I have a question.
Sure. Larry, are you asking the question?
Yes.
Okay.
Could the doctor comment on the use of amantadine with Ritari?
Yep. So amantadine is a very old medicine, actually used for the flu. And for some reason, it tends to work in Parkinson's disease, specifically in dyskinesia, or the involuntary movements that you get from taking levodopa. So Ritari is a long-acting form of levodopa. It's little capsules that have immediate release and extended release levodopa that lasts longer. And many patients, when they take a dose of levodopa, whether it's the yellow cinnamon or Ritari, they have on time with dyskinesia. So they go on, but then they have involuntary movements like you see Michael J. Fox have on TV. So to decrease those involuntary movements, then we can use amantadine to try to decrease the dyskinesia. So we can start 1 tablet once a day and go up to 3 times a day. But the medicine is not very well tolerated. So many patients develop swelling in the legs. There's discoloration of the skin in the legs. It turns a kind of a red purple color. And patients can have confusion and or hallucinations with the medicine. So always we start at a low dose and gradually go up. And then if you tolerate it, we keep it. If not, we stop it and try something else. So there's newer versions of amantadine once a day, like Gocovri, that you can just take 1 tablet at night, or the renal dose, a much lower dose. And then for patients where amantadine doesn't work or they have hallucinations, then we would consider DBS or deep brain stimulation to get rid of the dyskinesia, or the Duopa pump to better stabilize your doses of levodopa throughout the 24-hour period.
Okay, thank you very much.
Thank you, Larry.
Dr. Ospina.
Yeah.
With Telemed, what about a new patient? Can you talk a bit about how that might work?
Yeah, so the new patient, we definitely want to have video so that we can see the patient and we can do as much of the exam as possible. And then many times we enlist the spouse to help us to see if there's rigidity in the arms and legs. And then like we had a patient the other day where he had essential tremor and Parkinson's disease. So we can have you draw the spiral and you can show us the paper on the video. So it can be done. I mean, the exam is not the greatest, but it's better than nothing. And then we would always supplement that when you come back into the office, that we would do a much better neurologic exam. But certainly we've enlisted spouses to do a mini neuro exam at home and help us look at the eye movements and have them right and see how stiff or rigid the limbs are. The other thing is that like starting new medications, many of these new medicines require us to fill out a form and the patient to sign the form for you to get samples of whether it's Gocovri or Ritari or that sort of thing. And many of the companies now are waiving that patient signature so that they can just call you on the phone and get a verbal yes, saying, yes, it's okay to send me samples of the new medicine or get me enrolled in a program for the new medicine. So we can do that as well for new patients and existing patients.
Thank you. And I think Rhonda Jeffries, did you have a question?
Yes, I do. Dr. Ospina, we live in Sholo, and my husband has an appointment with you next week. How are you going about seeing your patients?
So we can either do it on the phone, or if you are able to use Zoom, then we can use Zoom. Like right now, I send you a link to your email, and then you just click on that link, and then we would do a Zoom visit.
Okay, do we need to call your office and have that verified?
Yeah, so you just call the office when they call you to confirm the appointment. Just make sure that you give them an email address. And then we can send you the link via email, and then we would have a Zoom visit just like you are. So obviously you know how to use Zoom, so that it shouldn't be a problem.
Fantastic. Thank you.
Thanks, Rhonda. I think we saw Doris's hand up again. What can we help you with now?
Dr. Ospina, we've been in telemedicine with you for 2 years now. Do you think we need to come back and have a visual one-on-one appointment in your office? How long should you be doing telemedicine?
So obviously, yeah, especially for UMA patients, I'd like to see you at least once a year in person so that I can like see you and touch you and make sure that everything is going in the right direction. Like, you know, with the UMA patients, all new patients were always seen in person before Corona. But if it could come up to once a year, then that would be ideal. And then your rest of the follow-ups would be the UMA telemedicine.
Thank you.
Dr. Ospina, can you share with us any information about billing insurance, Medicare, on the payment and the side of it?
So for the billing, then Medicare now has a modifier, a G112. So we bill Medicare saying it was a level 4 visit, and then telemedicine, and you bill the telemedicine modifier. So they know that this was a telemedicine visit that was done during the COVID pandemic and that it should be covered.
Do private insurances then, like the supplemental insurances, or just somebody who doesn't even have Medicare, is there any regulations about how they can accept or
Yeah, so they all have their telemedicine modifier. So whether you're Medicare or private or regular insurance, then you would just use whatever modifier they're using. But everybody, and in fact, even, you know, the private insurance were much more liberal with their telemedicine than Medicare always was. So it was much easier to do telemedicine with Blue Cross Blue Shield commercial paying patients than it was ever for Medicare. I mean, Medicare had all these restrictions where it had to be a remote area and a rural area. And it had to be done at the other facility, couldn't be the patient's home. It had to be a Medicare facility. Whereas now, you know, you can have the visit from your home.
Yes, yes. So it's much easier rather than having to go into a facility that has it.
Right. So like in Yuma, you know, the patients go to, you know, an internist office and have the visit there because he's a Medicare point of service.
And there are, from what I understand, there are the appointments and then the checkup calls. Is that something different? You know, just a check-in kind of call versus.
Yeah, so then if you would, so Medicare only allows, you know, one telemedicine visit per whatever the time span is. I can't remember what it is right now. But if you have to see the patient or talk to them in between, then that would be another kind of visit, like a checkup. So that it would be billed under a different modifier.
Lynn had a question, I think. Lynn?
Yep. My question has to do with arthritis and Parkinson. Does the Parkinson's make arthritis worse? And at the moment, they've had me only using Tylenol to manage pain from arthritis. My knees are really bad, and I just wondered what effect PD has on arthritis.
So PD causes rigidity and stiffness. And certainly if your muscles are stiff, it'll make the joint stiff. But it doesn't make arthritis. It doesn't cause arthritis. And then the way to tell whether something is arthritis or Parkinson's disease, if your symptoms wax and wane with the medication, so your stiffness, rigidity gets better as you take your Parkinson's medicine, and as it's wearing off, those symptoms come back, then that's Parkinson's disease or stiffness from the Parkinson's disease. If it's there all the time, regardless of whether you're on or off medicine, then that's TMB, too many birthdays, that's your arthritis. And so that's how you tell what's what. But certainly if you're very rigid and stiff, it'll make the arthritic pain worse.
The weather certainly makes it worse.
The
rain and cold we had was just agony.
Right. Mm-hmm.
So that was arthritis.
Yeah. So exercise is going to be your best friend, both for the Parkinson's disease and to make sure that those big joints like hips and shoulders and knees don't lock up, that you want to maintain the range of motion in those big joint so that you can maintain your mobility. So doing exercise is very helpful.
Despite the pain.
Despite, well, that's where you take the Aleve or the ibuprofen to allow you to be able to exercise. Just like with Parkinson's disease, many times you might need to take a little bit extra dose of medication to get through rock steady boxing or your physical therapy so that you can physically do the exercise. You know, if there's not enough gas in the tank, then you can't push through the exercise.
Okay. Yeah, they told me only to take Tylenol for pain, not to take ibuprofen.
Okay, yeah. Oh, especially during now the pandemic. Mm-hmm.
Okay.
Dr. Ospina, to ask you, I know you're familiar with our empowerment booklet that we have, the list of symptoms. For those of you who may not know, PMD Alliance has an empowerment booklet with an extensive list of symptoms. And it was developed to promote communication among you and your family and you and your physician, and to track your symptoms and their severity and how they change over time. Do you find that helpful, Dr. Ospina, in your appointments with patients that use the booklet?
Right, yeah. So the booklet, and then, like, you know, we always have them track their medicines, and always when you come into your appointment, we're always mapping out your medicines and what time you're taking it so that we can see in a 24-hour period where you're on and where you're off. And so when you tell me when you have dyskinetic movements, I can figure out, is that peak dose dyskinesia or diphasic dyskinesia? So having those symptom trackers or medicine trackers are very helpful. And then it gives you a much clearer idea of what's happening during the day. When are your low periods? You know, when are you going too many hours between doses of medication? And then it's easier to fix those symptoms. So especially with peak dose dyskinesia, you know, did you take your medicine and then 30, 40 minutes later, did you get dyskinetic or wiggly? Or did it come 3 hours later as your medicine is wearing off? Then, you know, because the fix for both of those things are different. And that way we have to pinpoint what kind of dyskinesia or what kind of dystonia you have. So many times dystonia means an abnormal contraction of a muscle. Many times the foot turns in or the neck turns. And then we need to figure out, is that happening at the end of the dose or as the dose is peaking? And then we can fix it that way.
Okay. Looks like we're running out of time. There was one question that was in the chat that I'd like to bring up. Whether there's an advantage of bridging the effect of simply Sinemet with an ER version there are between the pills. Is that a good idea?
So we want to use the longest acting form of the medicine, because when you're taking oral medications, remember that Parkinson's affects all of the muscles of the body, including the muscles of the gut. Because the gut is moving slower, more fluid gets sucked out of the stool gets hard, and you get constipated. Once you're constipated, that gastrocolic reflex doesn't work. So you swallow your pills and they sit in the stomach longer than they should. So instead of going from the stomach into the small intestine where they're actually getting absorbed, they sit there for 60, 90 minutes and you get a delayed on. So the longer acting forms of the medicine, whether we can use a once a day Mirapex ER dopamine agonist, or we can use Rytari, a longer acting form of levodopa. We don't have to make it from the stomach into the small intestine so many times during the day, especially if the patient is constipated and everything's backed up. So we like to use longer acting forms of the medicine, like once a day dopamine agonist or the patch that goes through the skin. And then the longer acting forms of levodopa are always the better ones, because we only have to make it into the small intestine 3 or 4 times a day instead of 5, 6, 7 times a day. So then many patients, we don't use Sinemet CR as often as we used to, because many patients say, oh, Sinemet CR stands for crummy release, because you swallow the pill and then it stays in the stomach and it doesn't go where it needs to go. So many patients say, I took it and nothing happened, or it took an hour to kick in. So we prefer now to use more Rytari, a longer acting form of levodopa. And then we can certainly bridge the doses of your levodopa with things like Inbrija, an inhaled form of levodopa, to get you from one dose to the next, especially if you had a lot of physical activity. And then later on in the year, a sublingual dose of apomorphine is going to come out as a rescue medicine that will also help you bridge the gap between your doses of levodopa. So there's lots of new stuff coming on board.
Vitari sounds like a good idea. Mm-hmm.
So that was your question, right? Okay.
So I mean, it's the reason why your doctor, it's not that we're always choosing the most expensive medicine, is that we're choosing the medicine that works the most like the normal brain. So the normal brain gives you a continuous infusion of dopamine over the 24-hour period. It doesn't pulse you with dopamine every 3 to 4 hours. So the longer acting forms of these medicine, then that's where we want to go because it works more like the normal brain.
Okay, well, it looks like we've done a full hour here. So I want to thank you, Dr. Ospina.
Thank you, Dr. Ospina. This has been great.
Yeah, you're always so good at taking all the questions and explaining it so we understand. And I want to encourage all of you to keep checking with PMD Alliance and reading our emails and joining us for any of our online programs. We're doing a whole bunch of them. And we love to see, you know, familiar faces and new faces at all of them. Rachel, did you want to say something?
I just wanted to thank everybody for coming today. Part of the day is just showing up for it. So thank you all for showing up, and we are thrilled to be here for you. And thank you, Dr. Ospina. This has been wonderful. Everybody who's on video, wave goodbye. Thank you. Bye, everybody.
Bye.
Thank you. Hi, Dr. Ospina.
Bye-bye.
Bye.